Hello and welcome to another Intensive Care Hotline and intensivecareathome.com live stream. Thank you so much for coming onto the show, and thank you for watching this on replay. And you are more than welcome to type your questions into the chat pad. Today is another episode of Ask Me Anything, and you can ask me anything as it's related to your loved one in intensive care, or if you have questions about intensive care at home. That is what today's session is about. Now, before we go into today's questions, what makes me qualified to answer questions for families in intensive care? Well, again, my name is Patrik Hutzel. I'm a critical care nurse, and I have worked in critical care close to 25 years now, where I have also worked as a nurse unit manager in critical care. I have worked in critical care for over 25 years, as I said, and I have been consulting and advocating for families in intensive care as part of my intensivecarehotline.com since 2013 all over the world. And I encourage you to check out our testimonial section at intensivecarehotline.com as well as at intensivecareathome.com. I can say without any hint of exaggeration that we have saved lives with our consulting and advocacy. You can verify that at our testimonial section and also at some of our client podcasts on our podcast section at intensivecarehotline.com. I'm also the founder and managing director of Intensive Care at Home, where we send intensive care nurses and critical care nurses into the home for predominantly long-term ventilated adults and children with tracheostomies as a genuine alternative to a long-term stay in intensive care. And we have been doing that for the last 11 years as well. We have been in business for over 11 years. And with Intensive Care at Home, we are currently operating all around Australia in all major capital cities, as well as in regional and rural areas. We are an NDIS approved service provider, TAC approved in Victoria, NIISQ approved in Queensland, iCare in New South Wales, DVA approved all around the country. We have received funding through public hospitals, departments of health, as well as private health insurance. And even if you are not in Australia, if you are in the US or in the UK and you need help with intensive care at home, I encourage you to reach out to us. We can help you privately. We also provide level 2, level 3 NDA support coordination for intensive care at home in Australia. So without further ado, let's look at today's questions. And once again, if you have questions, please type them into the chat pad, or if you don't want to type them into the chat pad and you want to talk to me directly, please join me live here on the stream. I have just posted the StreamYard link here. If you click on that, you can join me live on the show here and talk to me directly. You can either get on camera or stay behind the camera. It's up to you, but I'm absolutely looking forward to talking to you and answer your questions. So let's get into the first question. There are so many questions coming in every week that I will start with the first one. Let me just let me get to my emails. And in the meantime, if you have any questions, type them into the chat pad or join me live on the stream here, and then you can talk to me directly. I just need to get to my emails. Just give me 1 second. And first question is from Tiffany, who says, "Hi Patrik, my husband is 81 years old and had extensive surgery for a broken femur, as well as a hip replacement that had to be done a second time. He has not regained consciousness now for over 48 hours. The hospital moved him back to ICU and put him on oxygen. Why have they not done an MRI scan already? Is time of the essence in his case? The hospital is even suggesting it may not happen until tomorrow. So, Tiffany, I'm very sorry to hear about your husband's situation. Now, as well as that had to be done for a second time, he has not regained consciousness now for over 48 hours. The hospital moved him back to ICU and put him on oxygen. Now, I would argue that if your husband is back in ICU and has not regained consciousness and they put him on oxygen, they would have also put him on a breathing tube. Because if he has not regained consciousness, most of the time, a patient can't protect their own airway. And if they can't protect their own airway, they often need a breathing tube if they don't have a tracheostomy. Now, you haven't mentioned anything about a tracheostomy here. So from that perspective, I would think he is on a breathing tube and in an induced coma, and that might simply be part of why he's not regained consciousness. Now, also, with your husband's extensive surgery, he would have had a general anesthetic. So would it have been too risky for him to, quote unquote, wake up after the induced coma and be taken out of it straight away? Did he need a lot of anesthetics, opiate sedatives during the surgery that would have not enabled him to wake up, which is why they kept him intubated? Have you asked those questions? During surgery, for example, has he had blood transfusions? Was there extensive bleeding? Was there extensive fluid loss? Is your husband now potentially needing fluid resuscitation, potentially blood transfusions? Is he potentially needing inotropes or vasopressors to maintain healthy vital signs, right? The biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. And they don't know how to manage doctors and nurses in intensive care. And that is exactly what you are dealing with here. You don't know what you don't know at this stage, right? Once again, if he hasn't regained consciousness, he's more than just on oxygen. He's most likely on a breathing tube in an induced coma, because otherwise he wouldn't be able to protect his own airway. Now, you are asking, why have they not done an MRI scan already? I presume you are referring to him not waking up. So you want to know, has there been a neurological event? Has he had a stroke, God forbid? Has he had seizures? Is there anything else going on? Now, that brings me back to my original comment about, is he hemodynamically stable after surgery and not regaining consciousness, or after even double surgery, from what I understand? He may simply not be hemodynamically stable, i.e. his blood pressure might be fluctuating. Once again, he might have needed blood transfusions. He might need inotropes or vasopressor to get him hemodynamically stable. Is that one of the reasons why they haven't done an MRI scan yet? Is time of the essence in this case? I would say so. I mean, every case in ICU, timing is often of the essence, right? So I would say absolutely yes. And now you're saying the hospital is even suggesting it may not happen until tomorrow. Once again, what is the reason for the MRI? Or why can't they do it? Is it that your husband is simply unstable? Or is there simply no time slot for him to have an MRI? Right? That is the questions that I'm asking here. What is the reason for the delay? Is it a clinical reason? Or is it a resource reason? So what I mean by that, is there simply no time slot? Is there no staff in the MRI? Is it also a case of, if a patient is hemodynamically unstable in ICU, i.e. their blood pressure, heart rate is all over the place, up, down, potentially in irregular heart rhythm, do they not have the skill mix, the staff, to transfer a patient to an MRI that is unstable? Because that requires staff with experience, right? It also requires more than just one nurse and one doctor. It requires a transport team, right? It could simply be a resource constraint. Once again, the biggest challenge for families in intensive care is that they don't know what they don't know. But timing is of the essence here. Also, why did he go back to surgery for a second time? Again, Was there potentially some bleeding? Was there compartment syndrome, pressure on the wound? What was the reason for him going back? Because that might answer your questions, why he has gone back to surgery a second time and why he hasn't regained consciousness yet, right? I hope that clarifies, Tiffany, and answers your question. But one last thing here as well is get access to the medical records and get a second opinion, right? That's where I can help you, by looking at medical records or giving you a second opinion. That's what me and my team are there for, right? Okay, and welcome to all viewers once again, and also welcome to all viewers that are watching this on replay. Again, if you have any questions, type them into the chat pad, please. Or if you want to talk to me directly, just click on the StreamYard link that I put in the chat pad, and you can talk to me live here on the show. Let's look at another comment that has come in during the week from Cindy, who says, I agree with Patrik. There got to be more that we can do for the people without a voice. Thank you for giving so much help and info to the families who need it. Well, you're more than welcome, Cindy, and thank you very much for your comment. I really appreciate that. It was a comment after one of my live shows. I really appreciate that, Cindy, for the encouraging words. Then next question comes from Kay. Kay says, I want to know what is causing multi-organ failure. My husband is in ICU with multi-organ failure, but I really don't understand what is causing multi-organ failure. Okay, so now you're not suggesting why your husband is in or you're not saying what organs are failing. A lot of it comes down, what organs are failing. Okay, let's just say someone goes, let's just run through a few scenarios. Let's just say patient goes into ICU, on a ventilator with a breathing tube. The first organ that has failed is actually the lungs. If someone is on a ventilator, can't breathe by themselves, the first organ that has failed is the lungs. Okay, so then what can often happen from there, is a ventilator-associated pneumonia. Okay, so ventilator-associated pneumonia is a byproduct of the lungs failing. Then if a patient ends up with ventilator-associated pneumonia, they are at risk of going into sepsis and septic shock. If they're going into sepsis or septic shock, the next organ that might be failing is the kidneys, right? Then all of a sudden, you are having double organ failure. The lungs are failing and the kidneys are failing, right? So why are the kidneys failing in sepsis or septic shock? Because the blood pressure plummets and there is not enough kidney perfusion. Furthermore, there's a lot of toxins that will be set free during sepsis, also contributing often to kidney failure. So then you have double organ failure. Now, God forbid, and I'm taking an extreme scenario here, but this is how organ failure or multi-organ failure can happen, right? Then, for example, the patient is going to have a stroke, right, during all these episodes. Once again, then you have the kidneys failing, the lung failing, the brain's failing, right? Other causes, then, God forbid, the patient has a heart attack, then the heart is failing, right? So that's how multi-organ failure can happen, right? But there are other ways as well, such as, it can be attributed to, of course, post-surgery inflammation, accident, infection, increased metabolic rate, metabolic activity, and decreased perfusion. It is often a result of decreased perfusion. A lot of patients in ICU have a lowered blood pressure. They need inotropes, they need vasopressors, right? And that is often a result of lowered organ perfusion, right? This week, for example, we have been working with a client over the last couple of weeks, and their critically loved one has gone into kidney failure, right? And why have they gone into kidney failure? Well, they've had a low blood pressure for a sustained period, and the ICU team initially was not giving enough fluids and wasn't giving inotropes or vasopressors to maintain a mean arterial blood pressure above 65 millimeter per mercury, which is necessary for organ perfusion. Doesn't matter whether it's the kidneys, the liver, the brain, the heart. 65 millimeters of mercury mean arterial blood pressure is needed to get adequate organ perfusion with adequate blood and oxygen supply. Right. So now that we advocated for inotropes and vasopressors, now the kidneys are already working again since the MAP is above 65 millimeter per mercury. So you have to know what to look for. You have to know what questions to ask. It's very specialized knowledge that you only really have if you've worked in intensive care and critical care for as long as I have. You can get some of the stuff from websites and from textbooks, of course. By the same token, in order to connect the dots, you have to have that intimate clinical knowledge that only comes from decades of experience to connect all the right dots. Right? So a lot of it also comes down to, again, what is the underlying reason? If someone goes into ICU with a heart attack or, God forbid, with a cardiac arrest, then the heart is the first organ that's failing. And then, for example, the next organ that is often failing are the lungs. Right? Once again, the lungs are failing because the heart might not be able to cope with fluid overload, and then the fluids are pushed back to the lungs, right? And then patient might go into what's called pulmonary edema or fluids in the lungs and might need intubation, right? Or might need an induced coma to deal with that organ failure, right? And also, while we're talking about it, what are the signs of multi-organ failure? One of the signs is, again, often blood pressure is plummeting, inotropes are needed, vasopressors are needed. From organ to organ, right? Let's start from top, the brain. Okay, what does organ failure for the brain show? Well, altered consciousness, of course, confusion, unconsciousness, no responses. Then moving down to the lungs, what does lung failure look like? Hypoxia, no lack of oxygen, tachypnea, fast breathing or also shallow breathing, and then oxygen levels in the blood gas, PO2 is down, CO2, PCO2 in the blood gas might be up. In the renal system with the kidneys, obviously oliguria, lack of urine output, creatinine is going up, and urea or BUN levels are going up. In the liver, one of the effects obviously is that patients are jaundiced, bilirubin levels go up, liver enzymes go up, albumin is going down. And then if the blood system is failing, also known as the hematological system, platelets are down, protein C is down, D-dimer is up, and often a disseminated intravascular coagulation can be observed, right, where a patient might quite literally bleed a lot, right? So I hope that answers your question here. Okay, what might cause your husband's multi-organ failure? Before I move on to the next question, for all the viewers here, please type your questions into the chat pad. Don't be shy, or join me live on the show here by clicking on the StreamYard link that I put in the section here in the chat pad. Okay, let's look at the next question, and this is more of a real life case study at the moment. A client that we're working with. I just mentioned a minute ago that we are currently working with a client where we advocated for inotropes and vasopressors, successfully advocated for it to tackle the kidney failure, right? And urea and BUN levels were very high. And now I can already say that urea and BUN slowly are going down by having the kidneys perfused, right? So, that goes to show that, and for this particular client, the intensive care team's agenda was clearly to kill this patient, right? Clearly, right? When we spoke to the intensive care team, the agenda was clear to just stop life support and, wind everything down. This is for a 33-year-old man, and thankfully for now, we managed to get more time for the family to see whether their 33-year-old brother and son, can have a chance to turn this around. We don't know yet, but, at least we've managed to give them a chance. So that also comes down to multi-organ failure. Where is it coming from? In this situation, again, patient had a cardiac arrest, was hypotensive, not enough kidney perfusion. That's where the kidney failure came from. Now, Elisa, you are saying, I have a mother who's still in an LTCH. She still has the nasogastric tube that's been in since the 18th of November. I have been approached several times to get a PEG tube. How long can she keep a nasogastric tube after 3 months? Okay, great. What a great question, Elisa. So, you would have heard me say in multiple podcasts and videos and blog posts, don't give consent to a PEG tube, right? And I still stand by that. Now, there are exceptions to the rule. You will need, or your mum will need a PEG tube if, number one, she is, for example, a paraplegic or a quadriplegic, and that's irreversible, right? And she needs tracheostomy, she needs a ventilator. When neurological conditions are irreversible, also something like motor neuron disease, cerebral palsy, like I said, spinal injury, C1, C2, C3, that's when you probably need a PEG tube because it's irreversible in this day and age. Now, Elisa, my question to you is this. Is there reason to believe that your mom can be weaned off the ventilator and can have the trach removed? If the answer to any of those questions is yes, then your mom should stay with a nasogastric tube, right? If you could answer me, why is your mom in LTAC? And is there reason to believe she can come off the ventilator and the trach? And once I have the answer to that, then I can probably answer your question with much confidence. Right? It's not so much the length of time, Elisa, how long a nasogastric tube can stay in. It's probably more the question is why? Why does she have it? And the problem with a PEG tube is a PEG tube has the perception of permanency in intensive care, right? It also has the perception of permanency in LTAC or in skilled nursing homes or skilled nursing facilities. So it's got this perception that if someone has a PEG tube, they will never eat and drink again. Is that the perception you want to have? I doubt it. I very much doubt that you want the perception for your mother that she will never eat and drink again. Now, I had someone on this live show a couple of weeks ago who I believe was in a very similar situation, and they did not give consent to a PEG tube, and that forced the LTAC or the ICU to keep trying to give their loved one food and keep them trying to eat and drink. And eventually they got there. Very few patients that have a PEG tube will try and eat and drink again because no one bothers even trying. A nasogastric tube has the perception of it's temporary. Right. Okay, so now you're saying, Elisa, my mom is just having a trach. She's here because of respiratory failure, but has no lower respiratory issues, but upper respiratory issues, mainly the tracheostomy. She had a massive stroke. Okay, so she's not on a ventilator then. Have they done any swallowing tests? Right? So let's ask the next question so that I can answer your question. Have they done a swallowing test with the speech therapist? have they had the tracheostomy cuff down, the cuff deflated, and have they done a swallow test? She has, okay, and has had applesauce. Great. And has she tolerated the applesauce? Well, fantastic. So, why would you, okay, so let me make that distinction again, Elisa. A PEG tube has the perception of a permanent device. And that means people will stop trying to give your mom nutrition orally, food and drinks orally. They will stop trying because it's just so easy to attach nutrition to a PEG tube and just let it run in through a pump. It's very easy, a lot less work for doctors, nurses, and so forth, right? Whereas by having a nasogastric tube, again, the perception of a nasogastric tube in healthcare is it's temporary, right? And with something that's temporary, it will need to be removed. And the only way to remove a nasogastric tube is simply by getting people to eat and drink again, right? So I would strongly suggest to stay clear of that PEG tube. Strongly suggest that. Now I have another question. Is she tolerating the nasogastric tube? Is she trying to pull it out? Is she coughing? Is she irritated by it? Or can she tolerate it? Right? If she can't tolerate it, if she's trying to pull it out, fair enough, then you might need to look at a PEG. But if she's tolerating the nasogastric tube, I would stay clear of the PEG tube. Right? The only other thing that I will say is they might need to change, if she's got the nasogastric tube in the left nostril, for example, they might need to change it into the right nostril every 3 months or so to avoid pressure sores. Right? That's probably all that needs to happen. If she's making progress in taking in food, do not give consent to a PEG tube. Also, right. And also, Elisa, if you are giving consent to a PEG tube, I would also think it's easier for them to send her to a skilled nursing facility. It's probably not what you want. It's more likely for them to send us to a skilled nursing facility. And yes, they need to change sites, fair enough, but that's as far as it needs to go. So, excuse me. So I hope that makes sense, Elisa, and I hope that answers your question. Get them do the work. Get them do the work. And if they do the work, you will see that your mom hopefully can have that nasogastric tube removed. Thank you. Okay. Let's go to the next question. And please, if you have any questions here, type them into the chat pad or join me live on the show. I'll just post the comment here again. And not the comment, the link, the StreamYard link. If you want to talk to me directly here, join me live on the link here. Okay, in the meantime, let's look at the next question that is coming from Earl, who says, "Hi Patrick, I have a question and maybe you can at least help my wife and myself make sense out of the situation. My dad, 72, had a heart attack. He thought it was indigestion. They rushed him to surgery, placed 3 stents. He was eating after he come out of recovery and apparently had a massive heart attack due to blood clots at the stents. The second surgery with 3 more stents, and has been on the ventilator ever since, about 30 hours now, and a feeding tube as well. Since then, he has had seizures, developed sepsis, and pneumonia. Is the ventilator keeping him alive, or is this a normal procedure to help him through everything and the lesser risk? Any information would be appreciated from Earl. Right. Okay, Earl, if he had another heart attack after they put in the first 3 stents, which is also called an angioplasty. So he would have had an angioplasty as part of an angiogram in the catheter lab. And as soon as they put in the stents, they should have anticoagulated him. So what that means is anticoagulation is needed, such as Plavix, warfarin, heparin, to keep the stents patent. If you're putting in stents without anticoagulation, the stents will clot off in no time. Okay, which is probably what's happened here. So then they did another 3 stents, and then, but at that stage his heart could no longer cope. His heart probably decompensated, which is why he ended up in ICU on a ventilator with a breathing tube in an induced coma. Right? So since then, he has had seizures, developed sepsis and pneumonia. Yeah, I'm not too surprised that, you know, after his heart decompensated for a second time, that he potentially ended up with a pneumonia. Might be a pneumonia resulting from the heart attack. It might be a pneumonia simply from the from a ventilator associated pneumonia, right? Or another thing that might happen is if he had another heart attack and he became unconscious, has there been something like aspiration? Has he aspirated? Right? So those are the questions you need to ask in a situation like that. So is the ventilator keeping him alive, or is this a normal procedure to help him through everything and the lesser risk? Well, the ventilator is keeping him alive. Probably after the second heart attack, he could no longer protect his own airway. He probably stopped breathing. So it makes perfect sense that they started him on the ventilator. And yes, it does keep him alive. However, the stents are also keeping him alive, right? The nasogastric tube, the feeding tube, is keeping him alive because he's getting nutrition, right? Also, what most likely happened, his blood pressure crashed, most likely, and then he probably needed inotropes or vasopressors, right? So now he's probably also on sedation, on sedatives, right? So there's probably a lot happening here, right? Is the ventilator a lesser risk? No, not really. Ventilating someone comes with a lot of risk and comes with a lot of side effects. By the same token, not ventilating him, you know, he probably would have died, you know, and that's why he's in intensive care, to get that life support, right? And, you know, that they can manage that. He can't have the mechanical ventilation outside of intensive care without a tracheostomy, right? So where to from here? Well, what needs to happen next here, Earl, is, you know, he needs to be slowly woken up. They need to obviously make sure he's got the anticoagulation, such as Plavix, clopidogrel, heparin, or warfarin, to keep the stents patent, right? Otherwise, they clot off, and he might have another heart attack, which, you know, he might not survive, right? So next, he needs to be woken up, right? So the sooner the better. But if he's having a pneumonia and seizures, right, and sepsis, he might be hemodynamically very unstable, right? If he's having pneumonia and sepsis and seizures, he would be getting anti-seizure medications, such as Keppra or phenytoin most likely. He might also be on benzodiazepines, such as midazolam, to prevent seizures. But those medications all come with sedative effects as well. Therefore, it might take longer for him to wake up. Next, if he's got a pneumonia, they need to find out what sort of pneumonia is it. Is it viral pneumonia? Is it bacterial pneumonia? Right? And is he responding to antibiotics if it's a bacterial pneumonia? Is he responding to antifungals if it's a viral, if it's a fungal pneumonia? Is he responding to antiviral therapy if it's a viral pneumonia? Right? With the sepsis, is he hemodynamically unstable? Does he need inotropes, vasopressors? His white cell count is probably high. His temperature is probably high. Have they started him on steroids? Right? Has he gone into kidney failure, God forbid, or into any other organ failure? Right? So I hope that makes sense. Also, what's the cardiologist saying here? He had 2 massive heart attacks. What is the cardiologist saying here? What's next? Right? I hope that answers your question there, Earl. Now, for our viewers here, feel free to type your questions into the chat pad. Don't be shy. Or join me live on the show here. Ask me questions here, either on camera or if you're off. If you want to stay off camera, it's fine with me too. Just click on the StreamYard link here or type your questions into the chat pad. Don't be shy. In the meantime, I have a question here from Nico who says, I'm very frustrated by the communication with the doctors. Now, Nico, you haven't gone into a lot of details here. However, again, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And I think that's exactly one of your problems here. You probably don't even know what you don't know. So one thing that we're constantly finding is when we are working with clients one-on-one, that, there's so much territory that families in intensive care simply don't know needs to be covered. They are trying to connect the dots, but they're missing a lot of the dots, right? Which is why you need someone like me who has worked in the industry for decades. All right? You can't be flying blind. If you want to communicate with the doctors, first off, you need to ask the right questions. So once again, case in point, the client that we're currently working with, or one of the clients we're currently working with, just by me asking questions has changed the course of their loved one's life. I can say that without any exaggeration whatsoever, right? And it's the same for you. You need to ask the right questions, Nico. Okay, Dawn's got a question. You are saying, we contacted you about 2 weeks ago. We had to move my grandmother to an LTAC, but we found one in another big city, and she's in a hospital, within a hospital. Okay. So far, the doctors have been on great communication with us and each other. Okay, great. I'm very pleased to hear that, Dawn. I do remember talking to you and your mom. I do remember that. Well, I'm still opposed to LTAC. And if you feel like you had to move your grandmother to an LTAC, I still disagree with that. We never had clients having to move their loved ones to LTAC as long as they follow advice and as long as they follow guidance. We've never had that, Dawn. But that's okay. It is what it is. I'm sure you're making the most out of it, And I'm sure you won't have them walk all over you. Okay. Next question is... Next question is, from Alberto. Alberto says, yeah, it's a pleasure, Dawn. I'm glad you've learned something, and I know that, you know, my free advice is just as good as my other advice. I'm glad you've learned something, you know. But it's also very important for anyone watching this that you take full responsibility for what's happening. You can't be blaming other people. You can't be blaming the intensive care team. You need to take action, and you need to take full responsibility, because that is when things are changing for you, when things will be changing for you. Okay, then I have a question here from Alberto, who says, is a tracheostomy truly needed? And I know I've made a video about this, a quick tip, a few weeks ago. If a tracheostomy is truly needed, that's actually a good question, but it really depends, right? So I'll give you some examples. You know, if someone has been on a ventilator 10, 14 days, and they have been on the ventilator with a breathing tube, and they can't be weaned off the ventilator, and, you know, but they're still moving forward, they've come off sedation, they're getting more awake, you know, maybe you need to give it a couple of more days to see whether someone can be extubated, right? In that instance, a tracheostomy might not be truly needed. Let's take another example. Someone contacted me the other day, and they were on a ventilator for 3 months in an induced coma, and they couldn't come off it. Is a tracheostomy needed there and then? Absolutely, because you're causing more damage by the induced coma than by doing a tracheostomy, right? So it really depends on the situation. Let's take another example. What if someone has a spinal injury, such as C1, C2, you know, spinal injury, and they can't breathe because of the nature of their injury, or MND, motor neuron disease, or cerebral palsy? Do they need a tracheostomy? Yes. So, you know, it really depends. Does someone need a tracheostomy that's only 2 days out of surgery, and, you know, is on a breathing tube with a ventilator, you know, and they're still in an induced coma, they haven't woken up yet? Does a tracheostomy need to be done there? Absolutely not, because there's enough time to get them off the ventilator, right? So it is a very case-by-case scenario whether a tracheostomy is needed or not. Very much a case-by-case scenario. It's not a one-size-fits-all. And that's the problem in ICU. You know, many doctors and nurses even think, oh, it's a one-size-fits-all. No, it's definitely not. Definitely not a one-size-fits-all. Okay, so again, for any of the viewers here, please type your questions into the chat pad, or join me live on the stream here. There is the StreamYard link in the chat pad. You can just click on it and you can join me here live on the show, either talking to me on camera directly or staying off camera and talking to me that way. Right? Okay, so next question is from Nelly. Nelly says, hi Patrick, my mother is not responding after propofol has been discontinued. How long will it take for her to respond? Great question. Nelly, if your mom has propofol and she's in an induced coma, now they've stopped it, chances are high she is also on opiates such as morphine or fentanyl. And if she is on morphine or fentanyl, there could be a delay in her waking up. Next question is, propofol is short-acting. And because propofol is short-acting, right, she should wake up pretty quickly. But she won't wake up quickly if she had other sedatives previously, such as midazolam, which is a benzodiazepine and it's long-acting. She won't wake up if she had a lot of morphine or fentanyl. There could be a delay. She won't wake up if she is potentially in liver failure, kidney failure, if she's potentially overweight, because it takes longer for, sedatives to be excreted, and sedatives might be stored in the tissue when someone is overweight, right? Next, has she had a CT scan or an MRI scan of the brain to rule out a stroke or seizures or any other neurological event, right? Have you asked those questions? Has she had the CT scan or MRI scan or EEG? These are the questions you need to ask. So then, Dawn, you are asking PEG tube drainage. Is it normal for a PEG tube to drain at the site? What do you mean by that? Do you mean like the PEG tube is leaking? Is that what you mean? Is the PEG tube leaking from the incision side, or is the PEG tube leaking from the tube itself? Can you tell me more? So what? Is it leaking from the incision side, Dawn? Is the PEG tube leaking from the incision side? Is the PEG tube leaking from the incision side, Dawn? Yes, okay, all right. No, it's not normal. Not normal. So here's what to do. Most PEG tubes are coming with a balloon, right, to keep the PEG tube in place. And if she's having the PEG tube with a balloon, the balloon is probably down. It's usually blocked with water for injection, right? And the balloon might be down. Now, some adults also have a PEG tube that doesn't have a block, doesn't have a balloon. It might just have a flange. And if that is the case, the position of the tube probably needs to be changed, right? So action steps here for you, Dawn, are to find out if she has a PEG tube with a balloon or a PEG tube with a flange. That is your next step. Again, simple solution for a PEG tube with a balloon. She probably needs the balloon checked, and probably there needs to be more water put in. If she has a flange tube, she might simply need a PEG tube change. Okay, no need to panic. Just something for you to keep an eye on and manage, right? Not a big deal, I would say, but it needs to be fixed. Right? So then, again, for anyone watching this, please type in your questions into the chat pad. Don't be shy. And I am not sure there's someone Apple official, whether that's spam. If it's spam, I will need to, unfortunately get you out of here. I'm very open to talk to anyone, but not to spammers. So just ask your question, Apple official, so I can see you're not a spammer. Please. In the meantime, I will answer the next question. We've got a few more minutes left if anyone wants to ask a proper question. Okay, next question is from Donna. Donna says, my husband is waking up from medically induced coma after 12 days. It says my husband is not waking up from medically induced coma after 12 days. Right, Donna, I'm very sorry to hear that. Once again, similar to other questions, how long ago have they stopped sedation? Is your husband in liver failure, kidney failure? What type of sedation did he have? What opiates did he have? What's holding him back? Right? What is holding him back from waking up. Again, is it the type of sedatives and the amount of sedatives he's had? Is it the opiates he's had? Right? Those are the type of questions you need to ask. Is he in kidney failure or liver failure? Right? Because if he is, then you have another challenge. Right? And those are the type of questions you need to be looking for. Right? Has he had a CT scan of the brain, an MRI scan of the brain, an EEG? Has a neurologist seen him? Right? Those are the type of questions you need to be asking Donna. Right? And 12 days, after 12 days, it also depends on how many days has he not woken up. Is it 12 days or is it 1 or 2 days? Right? So a lot of it depends on that as well. I hope that answers your question, Donna. Now, we've got here Apple Official, but that seems to be spam. I need to take you out of this because I can't have a spammer here, because that's what it looks like you are. Okay, so next question might just be a comment. From Glenn, who says, my husband is 50 years old. He overdosed on prescription pain pills. He had an anoxic brain injury, was on a ventilator for 9 days. I was also told he was brain dead, no quality of life. They said when taken off the ventilator, he would pass away. We took him off the ventilator. I sat with him for 27 hours, waiting on him to take his last breath, but I was talking to him saying, please fight and come back. At that point, he squeezed my hand. I had to fight to get him back on feeding tube and water. Then he went in a coma for days after moving into palliative care. They again urged me to let him go. I refused. He woke up 1 week later and said my name. They removed the feeding tube, wanting a PET tube to feed him. I asked for him to be checked first to see if he could swallow, I guess, what he swallows. We are now in a skilled nursing home. He's improving slowly. He knows me. He walks slowly with support. My question is, how fast do you think he will recover? This is the love of my life and I want him back. His memory is bad. He seems lost. Okay, that's a good question. I don't have the answer for you. How long will it take for him to recover? I ask you another question, Glenn. I don't know whether you have children or not, but let me ask you this question. For anyone who's watching this who has a child, how long do you give your child to learn walking? How long? Until they walk? 8 months, 12 months, 15 months? Let's just say you set yourself the goal 15 months, or you set the child the goal to walk at 15 months of age, and then they don't walk at 15 months of age. What will you do? Will you say stop? Don't learn to walk? Will you do that? Or will you keep going? Well, I think you will keep going. It's the same here. It's the same here. Keep going. He has made a lot of progress. They told you he's not going to survive, and yet he's making progress. Right? Keep focusing on the positives, not the negatives. Keep absolutely focusing on the positives. I'll get into a little bit more detail with this question next time, but I got to wrap it up for today. We're coming to the hour mark. I want to thank you all for joining me here, and for sending your questions through. Absolutely, Elisa. Glenn needs to keep going. Absolutely. We all need to keep going, irregardless, right? So I will get into more detail next time. Now, I would really appreciate if you subscribe to my YouTube channel if you find value in it for regular updates for families in intensive care. You can also join the YouTube lives. Click the like button if you like the video. Click the notification bell for any new updates. Share the video with your friends and families, and comment below what you want to see next, what questions and insights you have. And just lastly, Dawn, can Klebsiella pneumonia cause blood infection? Absolutely. Absolutely it can. Absolutely. It can travel into the bloodstream. Now, I also offer one-on-one consulting and advocacy over the phone, Skype, Zoom, WhatsApp, whichever medium works best for you. Like I said, I have worked in intensive care for nearly 25 years in 3 different countries. I worked as a nurse manager for 5 years. I have been consulting and advocating for families all around the world in intensive care for over 11 years now, getting spectacular results by saving lives. You can look up our testimonial section or our podcast section with client interviews. We also have a membership for families of critically ill patients in intensive care, where you have access to me and my team 24 hours a day in a membership area and via email. And you will get access to that by going to intensivecarehotline.com, by clicking on the membership link, or by going to intensivecaresupport.org directly. Also, we offer medical record reviews in real time so that you can get a second opinion in real time. We also offer medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. I also represent you and advocate for you in family meetings with intensive care teams, so that you have representation and that you get best care and treatment for your loved one. And I'll make sure you don't get walked all over. I'll make sure you have a voice that speaks loudly for you and that can connect the dots clinically as well as from an advocacy point of view. Most families have no idea whatsoever. Right. Now, once again, share the video with your friends and families, give it a like, and subscribe to my YouTube channel. And once again, if you need help with intensive care at home, go to intensivecareathome.com, call us on one of the numbers on the top of our website, or simply send us an email to info@intensivecareathome.com. And consulting and advocacy you get at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or send us an email to support@intensivecarehotline.com. Thank you so much for your support, and I'll talk to you in the next video and on the next YouTube Live. I do those YouTube Lives every Saturday, 6:30 p.m. Eastern Standard Time in the US, which is 3:30 p.m. Pacific Time. It is 10:30 a.m. for me on a Sunday, Sydney, Melbourne time. So look out for the right time zone for the time, and I'll see you again in another one next week. Take care for now.